Let's proceed with the next session on the Symposium on Drug-Induced Liver Injury. For the same, may I please invite Dr. Piyush Ranjan, Dr. Manish Manrai, and Dr. Sandeep Satsangi to please be the chairperson for this session. Also, may I take the honor to invite the first speaker for this session, Dr. Harshad Devar Bhavi.
Yeah, first I would like to thank Dr. Duseja and his entire team for the invitation to be here. Thank you very much. My task today is to talk on drug-induced liver injury beyond the anti-TB drugs that we see so commonly in this country. India accounts for 26% of the 10.8 billion people with tuberculosis. And so it's not very surprising that the number of patients who developed anti-TB drug is so high. So you find that the entire debate on drug-induced liver injury in this country is hijacked by anti-TB drug hepatotoxicity, which is so very common, 46% in our Indian national series. But we shouldn't forget other drugs that also produce drug-induced liver injury, and they also lead to significant morbidity and mortality, and that includes the complementary medicine or the alternative medicines, anti-epileptic drugs, antimicrobials, and in India, the particular antimicrobial drugs is dapsone and non-steroidal anti-inflammatory drugs. When you compare it to other registries in China, USA, and Spain, you find antibiotics are still the dominant cause. Anti-TB drugs in China, whereas other antimicrobials in USA and Spain. But the two important drugs that are consistent are CNS drugs or anti-epileptic drugs that are common all across the registries. In USA, herbal and dietary supplement is the second commonest drug. So before I dwell into the particular type of drug-induced liver injury, I just go through these types of DNA, and we all aware of this direct hepatotoxicity or predictable hepatotoxicity, where you take a large dose of paracetamol and a developed drug in a few days. The second and the most common one is idiosyncratic, where it's generally dose related. Probably the incidence is about 1 in 10,000. And the classical drugs that are known to produce this is anti-epileptic drugs, dapsone, anti-TB drugs, etc. And a new variety called indirect, where it occurs about 4 months after you give a classical drug known as immune checkpoint inhibitors. Now, in idiosyncratic, and I like this classification very much, it was propounded by Jim Heimermann, where he said the idiosyncratic hepatotoxicity can be divided into immunological hepatotoxicity or immune allergic hepatotoxicity. The onset of illness is about 2 to 4 weeks, and there are classic drugs that produce this: cotrimoxazole, carbamazepine, phenytoin sodium, nevirapine, and they all present with what we now know as drug-induced drug reaction with eosinophilia and systemic symptoms. They all have rash, lymphadenopathy, fever. If you give these patients drugs once again after they have developed it, it comes with the vigorous severity and much faster with a higher mortality. And the treatment of choice is steroids. The second one is metabolic idiosyncrasy, and I think anti-TB drug falls into this metabolic idiosyncrasy because you can give the drug. Almost 90% of patients of anti-TB drug-induced hepatotoxicity in our country, we re-challenge them with the same drugs and they tolerate the drug. So this is metabolic idiosyncrasy. Now I'll focus on 4 important drugs. That's anti-epileptic drugs, antimicrobials, that's dapsone, immune checkpoint inhibitors, as well as complementary and alternative medicines. This is a publication from our series, in St. John's series, where we had 133 odd patients, constituted about 12.5% of patients, published just 2-3 years ago. And so you'll notice the top 4 causes are all the first generation, the older anti-epileptic drugs. And the 5th one is lamotrigine, which is a newer anti-epileptic drug. But again, as you'll also notice, that most of these drugs produce this hypersensitivity reaction, otherwise called a DRESS syndrome. And mortality is still high, 10% of what Hyman Zimmerman saw more than 60 or 70 years ago. However, I should mention that the newer anti-epileptic agents, which are known as second generation agents that have been manufactured after 1989, have a lower intensity of producing both hepatotoxicity as well as kill reactions, except for lamotrigine. And this is a publication from Dr. Naga Chalasani from the DILI group. They had 66 patients, and the top cause was lamotrigine, followed by the other regular anti-epileptic agents, that's the first line anti-epileptic agents. DRESS syndrome was seen in about 44% of patients, And both as well as our series and their series, most of these drugs that are used as anti-epileptic agents are used for non-seizure indications. They use for depression, they use for neuralgia, etc. And again, in their series, 10 to 12% of patients died and received a liver transplant. These anti-epileptic drugs have a propensity to produce DRESS, or DRESS syndrome, and you'll find it's highest with phenytoin and carbamazepine, decreases with phenobarbital, lamotrigine still has it, and even the newer ones, for example, with levetiracetam, it still occurs, but at a much, much lower frequency than before. So again, the newer drugs, very little chance of producing both hepatotoxicity as well as hypersensitivity reaction. Now, the second one that I wanted to focus was, amongst all antibiotics, it's the dapsone that we see very commonly in this country. Dapsone is given not just for leprosy, which is very common in our country, but it's given for a lot of non-leprosy indications like vasculitis, bullous disease, lichen planus. And again, this is one of those classic drugs where 90% of patients who develop dapsone hepatotoxicity is associated with hypersensitive reaction, particularly DRESS syndrome. There are mixed hepatitis, ALF seen in about 16% of patients, and mortality, unfortunately, ranges anywhere from 11 to 19%. Again, somebody has received dapsone, but a few months later or years later, he receives sulfonamides. Again, boom, it comes back with a much greater intensity, much greater severity, resulting much morbidity and mortality. And again, the treatment of choice for these patients is to give steroids. We also did some small series on HLA-B1301 with dapsone. Dapsone is very highly linked with HLA-B*1301, 4 patients, and we extended it earlier, about 8 patients now, and all of 4, plus another 4, all of them had HLA-B*1301, which tells us that having this HLA predisposes you to develop dapsone-induced hepatotoxicity. Now, drug reaction with eosinophil system syndrome is a fascinating disease. It's a multi-system disease. They get admitted in dermatology, they get admitted in mental health medicine, they get admitted sometimes in gastroenterology and several other diseases, including neurology. In our series, you had 19%. Otherwise, 1 out of 5 patients that we see has DRESS syndrome. They have skin as well involvement, mucosal involvement, as well as jaundice. And the important thing is, it's again restricted to a few number of drugs. And you find that the anti-epileptic drugs again come back as one of the prime causes of DRESS syndrome. Sulfonamides, dapsone, sulfonamide, sulfasalazine, trimethoprim, sulfamethoxazone. These are common implicated agents. Because we give TB in such large numbers, tuberculosis drugs are also responsible for DRESS syndrome. And then antiretroviral, particularly nevirapine, produces a classic DRESS syndrome and needs to be identified much earlier. Please remember that eosinophilia, which is one of those criteria for diagnosing DRESS syndrome, is seen in only 60% of patients. So many patients you see in your ward perhaps may not have eosinophilia. It's a very important clue to diagnose DRESS syndrome. I've already talked about India, but if you look at, and I've listed all the DRESS syndrome drugs across the world, you find that all across registries, allopurinol is one of the top 4 drugs in all Taiwan, USA, as well as Spain, Latin American countries. But again and again, you'll notice that the first generation drugs, carbamazepine and phenytoin, comes again and again as the top drugs, along with trimethoprim and sulfamethoxazole and lamotrigine. Now, there are key characteristics of well-defined HLA association with these drugs, and I have listed about 7 drugs, which are HLA association, the positive predicted value, and the use. And you'll notice that all of these drugs have separate HLAs that are associated with predisposition. Particularly, I want to bring to your notice carbamazepine, these 2 carbamazepine. They are not only carbamazepine drug-specific, but also phenotype-specific. For example, if you have HLA-A*3101, it only produces DRESS syndrome. It does not produce Stevens-Johnson syndrome. Whereas if you have HLA-B*1501, it predisposes to Stevens-Johnson, not to DRESS syndrome. And look at this, the positive value is either in single digits or low double digits, but the negative predictive value is 99 to 100%. So if you do the test and if you don't have this, then it's 100% likely you will not develop the DRESS syndrome. And because of which, lots of countries, especially in Southeast Asian countries, have mandated that these patients have to undergo screening before you administer these drugs. Those are drugs for hypersensitivity reaction. What about those which do not classically produce hypersensitivity? And this is Naga Chalasani has spearheaded much of this work. The first study was flucloxacin HLA B star 5701 in 2009, and subsequently you find a lot of HLAs that have been associated with drug-induced liver injury without systemic symptoms. Coming to immune checkpoint inhibitors, they have often seen but detected. Most of the oncologists don't even call us. Approximate time it comes is about 2 months. Hepatocellular pattern is more common, and very, very rarely does it produce jaundice or liver failure. In this slide, you will notice that if you use a combination agent as depicted by purple, the liver incidence is about, there's the fourth. Otherwise, all other organs you see much more commonly than the liver. So when you use the anti-combination agent, you find that immune reaction is seen to the tune of about 20 or 30%. But if you use these drugs singly, you notice that this hypersensitivity, you notice that DILI, drug-induced liver injury or immune reaction hepatotoxicity is seen in only about 5 or maximum 10% of patients. Now, this is a good study published last year because we use all of us have been exposed to immune checkpoint inhibitors with greater intensity because of the sheer number of patients who have developed HCC and who receive immune checkpoint inhibitors. So this is the study in the real world study, 375 patients, 495 non-liver transplant patients. And as you will notice here, the exposure-adjusted incidence of immune-related liver injury is significantly higher in hepatocellular carcinoma treated patients. It's about 11%, about 10 times higher than those who have no hepatocellular carcinoma. That's 2.5%. And what is more important, this is the overall survival is similar between both HCC patients and those without HCC patients and those without liver injury patients. Again, drug-induced liver injury resolution is seen on more than 72 to 80% patients. So generally very mild. And you notice this, only about 16% of patients received steroids in small doses, and most of them could be perhaps retreated with the same drug after a period of time. What about ACLF? Many of these patients are child's cirrhosis. The ACLF or cirrhosis decompensation occurred in only 7% of patients. Now, finally, I come to the complementary and traditional medicines. Patients often do not volunteer the history, and physicians often fail to elicit it and also probe it. We don't know what medicines they take. Many times, the ingredients are not very easy to find out. They come in various shapes, sizes, colors, the concoctions, etc. So it becomes very challenging, especially in this country, as to what type of complementary medicine they are taking. In India, and I have listed other complementary medicines throughout the world. In India, the topmost causes are Ctenospora cordifolia as well as ashwagandha. Ctenospora is otherwise known as Giloy. In China, it's multiform, and Tusanchi, which classically produces hepatic sinusoidal obstruction syndrome. In Taiwan, it's multiform again. In South America as well as USA is green tea as well as anabolic steroids. But these are all that are known. I want to take you this patient history, where it's something which is unknown that also can produce drug-induced liver injury due to complementary medicine. So this is Rishyagandha or Withenia coagulans. This is a husband and wife combination who took Rishyagandha for diabetes for 11 months. You see, both of them developed significant or severe hepatitis, including AST of more than 1,000 and ALT more than 10 times. Then you notice also that they have ANA positive as well as IgG is very high. And the simplified score is either 6 or 8, which is almost definite. And when you do a biopsy, it's almost classic of acute autoimmune hepatitis. Again, Rishyagandha has not been known to produce hepatotoxicity, but it's again very important that once you see this, work them up completely and at least present that in scientific fora or publish it. With regard to Ctenospora cordifolia, it was again first report was by Abha Nagraj, 6 cases. Subsequently, there are lots of reports that were published in JCEH, and then Kulkarni as well as Syriac, who spearheaded during the COVID epidemic, they had 43 cases. So I've just summarized these results for you. So total 58 patients of Ctenospora cordifolia, females more than males, bilirubin 10, AST/ALT more than 10-15 times, significant disease. And what is important is these people have that autoimmune hepatitis signature. Autoimmune hepatitis features were seen in 66% of patients. And patients who had underlying liver disease, and if you gave them Ctenospora and they develop significant disease, have a higher chance of mortality. Now, there was a backlash. As you know, every time you present something, there's a backlash. This is, again, the government backlash rebuttal saying it's safe, it's misleading, and Ayurveda is the best rejuvenating drug. But fortunately, ABBA did the analysis again and then proved to them that it was indeed Tunospora without any contamination. This Tunospora liver injury is not only in our country. It's also seen, for example, in this case report, which was presented from Nashville, and my good friend Benedict Malakal is one of the co-authors. It produces significant AST-ALT elevation, responded very well to just 3 days of steroids. Now, the second one is ashwagandha, which is used for all kinds of reasons. The USA group as well as the European group assembled the cases of 14 cases. Philip assembled his 8 cases. It produces cholestasis and then most of the time, fortunately, resolves. But if you give that again in patients who have underlying liver disease, there's a risk of acute and chronic liver failure. And this is my last slide. There's always been this backlash from the alternative medicine community. But I think at last, if you look at this, they go on to say that it's centuries old, it's been safe, and subsequently they say it's worth looking at it. It highlights serious issue. And finally, I like this last line. The need for establishing a robust pharmacologic vigilance system in India is imperative. So I think at last they have sort of embraced the idea that there is a problem and that we need to look at it much more carefully. So in conclusion, top 5 culprits I told you, 20% of all, at least DILIs in India have this hypersensitivity phenomena. Genetics matter. Certain HLAs are associated with particular phenotype as well as drugs. Clinically significant ICI is rare. Steroids help in managing DILI. And again, please give it as soon as they present to your hospital rather than when they already have developed signs of decompensation. And again, traditional medicines like Tunospora are known, but there must be plenty in this world which we do not know. Thank you very much.
Thank you, Dr. Harshit. Please join us on the stage. Now I request Dr. Kalyan to come and deliver his talk on drug-induced autoimmune like hepatitis current concepts.
Good afternoon, everyone. Thank you all for attending this session. These are my disclosures, none relevant to the talk. So the objectives in the next 15 minutes are really to talk about the new nomenclature, the diagnostic criteria for drug-induced autoimmune-like hepatitis, or at least an attempt to come with the criteria. Can liver biopsy help in diagnosing DI-ALH? I'm glad Harshit already talked about the ICI toxicity. I'm going to be very brief about this, and then we'll finish off with management and prognosis. So this is something that is extracted from Hamlet, where he thinks that it is amusing to see his uncle, King Claudius, who was scheming against him to get exploded with his own device, which is kind of what happens in drug-induced liver injury, where we actually use the drug with the purpose and the plan, and however, when it backfires on us, certainly none of this in this room thinks it's amusing. It's actually a tragedy like that of the fate of Hamlet. So it is a paradox that we see of autoimmunity in liver being a very tolerogenic organ. So liver, as you can see, it is constantly exposed to a lot of antigens from the peripheral blood and also from the GI tract. However, it remains usually in the immunotolerant stage. However, when there is a loss of tolerance, and in this case due to an immune trigger, and we'll specifically talk about drug being that trigger, again, in a genetically susceptible individual, and again, where environmental factors do play a role, I think then there is this immune overreaction that happens because of the peripheral immune cells and also the resident immune cells within the liver. So the previous published terminology was drug-induced autoimmune hepatitis, DILI with autoimmune features, immune-mediated DILI, and the classic example is ICI toxicity. Idiosyncratic DILI, which we all know is hypothetically immune-mediated. However, the last two are very distinct and they lack autoimmune features. So this was a task force by several different groups, mainly the International AIG group and the INASL DILI, and my co-speakers, Harshit and Dr. Chalasani, were part of this expert opinion paper. And they basically came up with this nomenclature and diagnosis and also management of drug-induced autoimmune like hepatitis. So the current preferred term is really drug-induced autoimmune-like hepatitis, which basically is characterized by positive autoimmune markers and a histology that actually mimics autoimmune hepatitis. So there are several biochemical phenotypes. Most usual phenotype is really the acute hepatocellular pattern of injury. The acute cholestatic is rare. And again, what makes the diagnosis challenging is there are several patterns, such as drugs that can unmask the underlying autoimmune hepatitis. We do have the true drug-induced autoimmune-like hepatitis, or autoimmune hepatitis that actually occurs after or persists after a drug-induced liver injury. So again, of all the different clinical and pathologic phenotypes of DILI, drug-induced autoimmune-like hepatitis is very distinct, and we're going to talk more about it in the next few slides. So there are several drugs implicated that can cause the DILH, and these drugs can be working on the immune system, respiratory system, and you can see a myriad of all organ systems in our body. And there are, again, drugs that are listed as highly probable, possible drugs, and then there are some that are reported, which are very historical. And if you look at the whole literature, at least more than 740 drugs were associated with immune-mediated injury, including the vaccines and the most recent COVID vaccine as well. So now coming to the epidemiology, the incidence of autoimmune hepatitis is approximately 1.37 per 100K persons, of which a tenth of it can be related to drug-induced autoimmune-like hepatitis. And again, if you look at the DILI incidence, it's about 14 to 19 per 100,000, of which about 3 to 8% includes the DILI diagnosis. So this is data from the recent FIRES database. This is an FDA reporting system. And again, you can see that most of this is actually clustered around individuals around after the fourth decade, and you will actually see a more female preponderance than males. Again, if you look at the annual incidence of it, although the evidence is lacking, the awareness and the recognition in the recent few years has been increasing, and this is the most recent paper from the FIRES database. So why is it so difficult? Again, not all drugs are the same. Most drugs have different latency, different odds risk, and again, the risks at the individual level can be because or mediated, or there's a crosstalk between the host genetics, the environmental factors, and also the drug metabolism enzymes and transporters that an individual could be lacking. So if you look at this graph that actually shows the odds risk of DILH, there are really 7 drugs that actually cross the odds risk of more than 10. And the classic ones are the nitrofurantoin, minocycline, doxycycline, atorvastatin, meloxicam, simvastatin, and nivolumab. Again, this is a checkpoint inhibitor. You'll see that the latency of these drugs also can be quite variable. Some of them are as short as 6 days, and some can actually last several months. The median range is approximately 3 months. So are there any diagnostic criteria? So like I said, usually this is a patient that we see in our clinical practice, usually has acute hepatocellular pattern of injury, and then has positive autoimmune markers such as AN and ASMA, and has elevated IgG. Now keep in mind that patients without liver disease can also have at least 40 to 65% of them can have these autoimmune markers. Approximately 5% do have elevated IgG. So they're quite nonspecific. Now, for DILI, you can actually use the causality assessment model, such as the RUCAM or the RECAM, but they do not clearly identify the DILH phenotype. Neither does the simplified AIH scoring or the scoring that is proposed by the AIG group. So, Bjornson and group actually came up with some criteria for drug-induced autoimmune-like hepatitis. So again, like we talked, the condition is characterized by positive autoimmune markers, histology, response to drug withdrawal, and if they don't respond, than the use of steroids. And again, lack of response after steroid withdrawal. And if you have at least 4 or more, it is probable. And if you have 3 or more, it's possible. So there are certain new biomarkers and strategies that are actually being investigated. If you look at immunoglobulins in classic autoimmune hepatitis, both IgG and IgM are elevated. There is a paper that was published as an abstract where in DILH only the IgM against the SCL70 and ssDNA and also the SNR and P are elevated. The polyreactive IgG is actually coming up as a new kid on the block. It is more specific and accurate in classic autoimmune hepatitis, but in a patient who you're suspecting drug-induced liver injury, and you're also trying to tease out which one of this is drug-induced autoimmune-like hepatitis, the PIgG can actually be a distinguishing factor. There are certain cytokine profiles which are being looked at that would actually differentiate classic AIH, DILI, not specifically DILH, and checkpoint inhibitors. And you can see in this graph that there are certain cytokine profiles that can tell us which one of these categories that the patient belongs to. Clearly, the genetic testing, we know that there is HLA predisposition and also certain SNPs that can account for the genetic susceptibility, but at a population level, it has low positive predictive value and not useful for routine testing. But however, it may establish the causality of a specific drug. Now, in the 5th AIH workshop, there was proposal for the use of AI-based models for long-term and also looking at registries in trying to tease out the DILH phenotype. So when we come to liver biopsy, is this helpful or not? So in classic AIH, we know that liver biopsy provides us confidence for long-term immunosuppressive therapy. In drug-induced autoimmune like hepatitis, it's not always necessary. But when we do it, the idea is for us to hope that it can distinguish between classic versus DILH. And again, if there is other competing etiologies, the biopsy would come in quite handy. So this was a paper that actually looked and kind of suggested that maybe the answer lies at the interface. And this was proposed by the Indiana group. And in this study, they actually looked at interface hepatitis, lymphoplasmacytic infiltrate, presence of eosinophils, and lobular necrosis, typically the more perivenular. And they thought or proposed that in their group, this was more severe in the classic AIH group than in the drug-induced ALH group. However, most of this was nonspecific due to the small sample size. The definition and the drugs implicated in this study were unclear. So the only thing that actually came out of this study was cirrhosis was actually present more in the AIH group than in the drug-induced autoimmune hepatitis group. And also remember to the previous theme that not all drugs are the same. So you would actually see higher inflammation grade, higher rosettes and fibrosis in the nitrofurantoin individuals than in individuals who were exposed to minocycline. So management of drug-induced autoimmune like hepatitis, I know Dr. Chalasani is going to talk about the management, but I'm going to specifically talk about some sticking points for DILH. So if you suspect DILH, the most important thing is to withdraw the implicated agent. Now again, most of this is not robust evidence. It's derived from retrospective case reports and evidence. And most of the time, the drug withdrawal alone would suffice. Now, if you look at recovery, the DILH group usually takes a longer time to recover just after stopping the drug than the regular DILI group. And when you really think of drug-induced autoimmune like hepatitis, the steroid use should be on an individualized basis, usually in severe DILI or non-resolution after 30 days, or in individuals that you want a faster recovery so they can get back on another type of treatment for their underlying use of the original drug, I think you should use steroids. Again, it is seen that the response to steroids is actually quite faster in the DILH group than in the classic autoimmune hepatitis group. What's not clear is the dose or the duration, when to start, when to stop, and the dose of the steroids. Prognosis, again, the strongest tools we have to diagnose DILH, re-challenge. It's actually a good proof of causality. However, the caution needs to be taken, especially like how Harshad mentioned, that re-challenge could cause acute liver failure, need for transplantation, or death. So again, not routinely recommended. Systematic withdrawal of the steroids after a few months is really the strongest tool that would help us in the diagnosis of DILH. Overall prognosis for this group is very good. Most return to normal liver function. There's a low risk of relapse and a low risk of progression to CLD. However, longer studies are needed. A very brief mention on ILICI, or immune-mediated liver injury from checkpoint inhibitors. It can be seen in 10 to 35% of individuals exposed to ICI. Mostly it's hepatocellular. There is an immune-related sclerosing cholangitis that also can happen, so be mindful of that. It is quite distinct from DILH because it does lack positive autoimmune markers. Underlying MASLD and the presence of HCC is usually associated with increased risk of toxicity, like Harshad mentioned in his talk. A brief mention about hepatitis C positive and hepatitis B core positive patients is they can safely receive ICI without a risk of reactivation. In surface antigen positive individuals, however, they would require antiviral prophylaxis before initiating the therapy. Liver biopsy has very limited utility, and almost all immune checkpoint inhibitor toxicity, even recurrent toxicity, does respond very well to immunosuppression. And not everything is bad. The adverse effects, especially individuals who have hypophysitis, it actually correlates with better cancer outcomes and better overall survival in those patients. So this is my summary slide. So drug-induced autoimmune like hepatitis is really the new term, which is characterized by positive autoimmune markers and histology that mimics autoimmune like hepatitis. There are several drugs that are implicated in this, but presentation is not uniform due to latency and underlying risks. There is no specific test. However, the best approach is to monitor the clinical course. Cirrhosis is less frequent. Long-term steroids and immunosuppression is less needed. Relapses and recurrences are less frequent. So it's not diagnosed by positive attributes, but lack thereof compared to the classic autoimmune like hepatitis. ILICI is a distinct immune-mediated phenomenon, and most individuals have normal IgG. Biomarkers, standardizing protocols, and AI, they're all underway. And thank you all for your attention.
Thank you. You please join us here. For the next talk, may I call upon Dr. Naga Chalasani for his talk on managing drug-induced liver injury in patients with chronic liver disease.
Thank you. I'm very happy to be here. Harshad, Kalyan, great talks. Wonderful, enjoy them. All righty, I will talk about DILI in people with background liver disease. It's an area that I've been interested probably for the last 20 years or so. These are my disclosures. This is the outline, a touch on direct hepatotoxicity in CLD. This is not something we discuss frequently. Much of the talk would be about idiosyncratic DILI. As Harshad has said, this is sort of a large component of DILI is idiosyncratic. Finally, some thoughts on how to manage DILI in people with underlying liver disease. It's already been touched on what is direct hepatotoxicity. This is predictable. You give large enough dose of a compound, most people will get it. The duration, the pattern are predictable, and there are excellent animal models for this. So I think you know this story. The paracetamol is hepatotoxic in people with underlying liver disease. If you have chronic liver disease, you can take up to 4 grams, but don't give more than that. I won't go too many details into this because this is pretty well explained phenomena. Whereas in people with alcoholic liver disease, the dose should be lower, just their heightened sensitivity. The recommendation is not to exceed 2 grams. Not only ALD, even people who are drinking heavy, I think it should be the case as well. The mechanisms have been sorted out, and I think there are even animal models to understand why this happens. As I was preparing for this talk, though, I was looking through some of the literature. There were actually a number of direct hepatotoxins that I didn't realize that are in the market. If you look at this list, for example, I think we know aspirin and salicylate. I didn't realize iron or ferrous sulfate or direct hepatotoxins. And if you look at propofol and a few other things like dexamethasone. So a thing that's not known, though, is unlike paracetamol, direct hepatotoxin, if you give it to people with underlying liver disease, it's clearly described that they will get more hepatotoxicity. In case of these compounds, a similar phenomena has not been observed in the literature. We just don't know why this is. It's also possible these compounds may have wider safety margin. Idiosyncratic is obviously the larger component of DILI cases we see. The key thing is these are unpredictable. Most people don't get DILI. It's just a rare individual that gets it. Over the years, though, when I started my work in DILI, the notion was idiosyncratic DILI was independent of dose. And then in 90s, some of the really brilliant researchers started to point out the liver failure from DILI is never seen with compounds given under 10 milligrams per day dose. So people started to piece this together to say, is there some dose relationship? I think there is. And I think, as you said, Harshad, the idiosyncratic is immunoallergic versus metabolic. For immunoallergic, there isn't a dose relationship, whereas the metabolic component of it, I think it is fairly dose related. I think especially if the compounds are also hepatically metabolized. So this was the first paper we published. Craig Lammert was back then a medical student who turned out to be quite successful researcher. Published a paper showing idiosyncratic DILI, there is a dose threshold, 50 milligrams or higher, more likely to have DILI and severe DILI as well. A year later, he published a paper, follow-up paper, showing if a compound is hepatically metabolized. Back then, I think we all knew that a compound is hepatically metabolized, more likely you're going to have a liver noise, never been documented. That's really the beauty of this particular paper. If a compound has more than 50% hepatic metabolism, you're more likely to see a DILI signal, and then also severe DILI. And in the same paper, you sort of combine the dose plus hepatic metabolism. I think this turned out to be really important for drug development. If a compound is given at 50 milligrams or higher, plus if it is hepatically metabolized, it's 2 hits, more likely to have risk for DILI and severe DILI as well. This led to Minjun Chen from FDA putting together a couple rules. One is called rule of thumb. This was entirely based on the work done at my institution, combining the dose and hepatic metabolism. Then he went on to do a rule of 3. Bottom line, though, if a compound is given at a large enough dose, and if it is hepatically metabolized and also produces reactive metabolites, that compound is going to have a DILI signal. That I think is sort of, and this led to pharma, as they're developing compounds, they carefully try to exclude these from coming into human studies. And then later on, though, where I'm going with all this is dose matters for idiosyncratic DILI, and dose, for a fixed dose, people with underlying liver disease may have higher exposure. Okay? This, the first came with the direct-acting antiviral agents. This we are talking about 10, 12 years ago. multiple direct-acting antiviral agents. For the same dose, people with decompensated liver disease would have much higher concentration. For example, AUC for Vicirapac could be 1,000-fold higher, 1,000% higher in decompensated cirrhotics. And guess what? There was a significant hepatotoxicity. First time linking concentration, serum concentration to DILI risk, that became quite evident or was illustrated in people with underlying liver disease or decompensated liver disease. And then in people with underlying liver disease, more so in people with Child's class B and C, for the same dose, you're going to have a higher exposure concentration. I don't have a slide, but the serum concentration or a Cmax more than 1.2 micromoles is a clear risk factor for idiosyncratic DILI. And people with liver disease, especially those with decompensated, more likely to have that dose. So I think theoretically it's possible metabolic type of idiosyncratic DILI is more likely to happen in people with underlying liver disease where the concentrations do build up. Just going to touch about the chronic liver disease and DILI. What do we know? Really, when you talk about DILI in people with underlying liver disease, two things come up. One, I think, are people at a higher risk. Number two, if they get DILI, do they have worse outcomes? I'm going to walk you through both of them. Fair bit written in the literature. This is a nice review by Jim Lewis and Jonathan Stein showing evidence in the literature of instances where a particular compound was thought to be at a higher risk in people with underlying liver disease. Widely quoted in the literature is anti-tuberculous treatments. I think it just requires more scrutiny. Some of the work is not as rigorous. There are a number of other compounds listed here as well. I would say, though, for this list here, although this come up repeatedly in review articles, the amount of supporting data are rather sparse. This is highly quoted. This is about 25 years old, I think now, showing underlying hepatitis B increases the risk of DILI from anti-TB drugs, and I think I've shown these data multiple times. Number of problems. For example, they define DILI as twofold increase in ALT, which is very low threshold for DILI diagnosis. But though most episodes of their DILI, there was actually an increase in Hep B DNA. Today, we would call that recurrent or reactivation of hepatitis B rather than DILI from anti-TB drugs. So this part, underlying Hep B, risk for DILI from anti-tuberculous treatments, in my mind, is not settled, although this is quite definitively stated in review articles. The same thing with antiretroviral therapy and viral hepatitis. You read textbooks and this comes out quite repeatedly, but Ken Sherman and others have strongly argued this is nothing to do with DILI, this is more to do with immune reconstitution from antiretroviral agents. In terms of chronic DILI, though, and then I think there is acute DILI we all are worried about. There are compounds like nitrofurantoin, diclofenac, and minocycline that cause chronic DILI. There are some instances in the literature where underlying liver disease increases the risk for chronic DILI. Tamoxifen is sort of a prototype. If you have underlying NASH, the risk of progressive NASH from tamoxifen is significantly higher. Interestingly, some ethnic or some parts of the world, Japanese seem to have much higher risk for tamoxifen, NASH or MASH, or its progression. Other things are written here. Methotrexate, amiodarone, iriotecon, and stevudin. And then also have in the footnote two drugs which actually never made it through FDA for marketing. One is called peglispro, the other one is a novel glucagon receptor antagonist. They both caused chronic DILI from hepatic steatosis. This was linked to PNPLA3. And both were from my hometown company, Eli Lilly. And this was pretty interesting. I think at this time, there were very few compounds that caused sort of NASH-like picture well documented in clinical trials. So this is a paper that we published now 20 years ago. When statins, there was a lot of apprehension to give statins in people with underlying liver disease in late 90s and early 2000s. Especially patients with MASLD would have a high ALT, and the package insert at the time said not to give statins if you have liver disease. In this study, we have shown that if you have an increase in ALT or background MASLD or NAFLD at the time, the risk of serious hepatotoxicity from statins wasn't higher. So this actually turned out to be, I would say, an important paper. This led to change in the FDA labeling, and this has been followed by about a dozen papers or so. Now the guidelines strongly recommend using statins in people with underlying liver disease. In terms of MASLD as a risk factor for DILI, sort of emerging data, though I was happy to see MASLD as showing up as a risk factor for immune checkpoint inhibitor DILI. In terms of other compounds, there's a paper from our group showing if you have background MASLD, risk of DILI from any compound is about 5-fold higher. And there is a Korean paper after our paper, showing a similar phenomenon as well. They use sort of the incidence relative risk is about 7-fold higher. An old Italian prospective study showed the same thing. So collectively, NAFLD or MASLD, patients with MASLD may have higher risk for idiosyncratic DILI. These are all epidemiological studies requiring more attention to this. INH hepatotoxicity in cirrhosis. I think fair bit of clinical data. This is puzzling though. I could understand in a decompensated cirrhotic or alcoholic hepatitis, in a compensated cirrhotic, why INH would be hepatotoxic, especially if it is given by itself for latent TB. You would have to think this is related to two things: dose it is given, 300 milligrams or higher, as well as INH is hepatically metabolized and it does produce reactive metabolites. That may be the combination of it. But I do think just the textbook description of 3 to 5-fold higher risk of DILI in people from INH in cirrhotics, I think it just requires more scrutiny. We just need to better understand that. The next part is, do people with liver disease have heightened risk from DILI? The answer is yes. This is a paper we published. If you have chronic liver disease, the risk of dying from DILI is about 5-fold higher. Two other data sets, one from Dylan, followed by one from Andrade's group in Spanish registry, showing the same thing. Not a surprise, right? If you have DILI, you're going to have poor outcomes if you have underlying liver disease. Nonetheless, these papers documented that and quantified the risk. How do you manage it? What I've been telling, at least in clinical trials of patients with underlying liver disease, just avoid compounds that are known to cause DILI. In our world, things like amoxicillin, clavulanic acid, so on and so forth. It has not caught on. But nonetheless, this is one. If you're serious in your cirrhotic, wanting to avoid DILI, especially Charles B and C, I think paying attention to what kinds of compounds they're given. And I've been avoiding amoxicillin, clavulanic acid, and nitrofurantoins of the world. Just other thoughts on management. In general, do not re-challenge, especially if there is a reasonable alternative. Both of you have touched on it. Anecdotally, I found success with dose titration. Start low dose, and I think we have had some patients with Mycobacterium avium intracellular, and they would get DILI, and we've been able to slowly build the dose up, and I think we've been able to get through. And I've done a pre-medication with low-dose steroids, especially if the primary episode was managed with steroids. You can start low dose, give them steroids, and I think this is what happens with immune checkpoint inhibitors. Finally, though, occasionally I've pre-medicated with S-adenosyl methionine. I think if you go to China, I think there are just a high usage of SAMe to prevent liver injury. So that's another trick that in your practice, somebody with NASH cirrhosis, they need a hepatotoxic drug. These are the things that you might try to minimize the risk of DILI in them. Just to summarize, I think the DILI, at least the metabolic idiosyncratic DILI, is dose-related. In people with underlying liver disease, obviously the concentration is going to be higher. So that's where I think the increased risk of DILI in people with underlying liver disease is sort of dose-related. And then we touched on the risk of DILI in underlying liver disease is compound-specific. For example, statins do not have heightened risk, but some other compounds, for example, maybe isoniazid, maybe. So I think more work needs to be done. And in terms of DILI outcomes, and I think we all agree, if you have DILI in the background of cirrhosis, that's just bad news. And the re-challenge, avoid it. And if you need it, slow introduction, dose building up might help you. I think that's my last slide, and I thank you for your attention.
Thanks. I think we can open it for some questions. If I may start, Dr. Kalyan, this was regarding your talk on drug-induced autoimmune hepatitis. Would finding fibrosis on histology make you think of true autoimmune hepatitis, or would it still be okay that a drug duration of say only 5 days of nitrofurantoin? It's an acute process. How would that lead on to fibrosis?
Yeah. So again, in clinical practice, there are patients who actually have been previously exposed to nitrofurantoin and would actually respond to nitrofurantoin. They may have not been diagnosed with a drug-induced autoimmune hepatitis in the previous episodes, but it is possible that the second and third could have caused the underlying fibrosis. So really, fibrosis at a significant level should actually raise the flag that this could be an underlying classic autoimmune hepatitis. Low levels of fibrosis, there's not that much that you can decipher from a biopsy.
Dr. Sunil?
Yeah, Dr. Kalyan, very interesting talk. So I have a similar question right here, Kalyan. So what is the true indication of doing biopsy in drug-induced AIH? Because, it's very difficult to differentiate between the two. And as Dr. Sandeep said, that fibrosis might not be there in acute AIH. It might be true, pure AIH where you don't have fibrosis. So true indication.
The true indication is really, the hope is to distinguish, is this classic AIH, especially the severity of or the magnitude of your liver enzymes that are high? Do you want to just withhold the drug or the suspected drug, or do you want to actually give steroids early on?
No, if somebody has deranged LFTs, obviously you're going to hold that drug.
Yes. And do you also want to do steroids rapidly? Do you want to
And
start
second
steroids
question,
soon?
yeah, thank you. My second question is for Professor Nagas. What is your reintroduction strategy for anti-tubercular drugs? Because there's conflicting evidence that you can start one drug at a time. You start INH first, you can start rifampicin first, or you can start all the three drugs together. What should be the reintroduction strategy?
Honestly, I have no experience. Maybe Harshad is so much better with anti-TB. Harshad, do you want to take it?
I've answered this question many times. I've answered this question many times, but at the cost of repetition, I will tell it again. So clearly somebody has developed hepatotoxicity, and TB induced hepatotoxicity, anti-TB, is much more severe, by the way, than any other disease. So and the unfortunate part is these people have taken it for a curable disease, and they develop a severe disease. The adaptation rate is 20-25%. And then at least 10% of patients go on to develop severe disease. Many of these patients who develop severe disease, 75% of them go on to develop acute liver failure. So basically, it's a very severe disease. So how do we restart when we have no other options? Give them the least hepatotoxic drug first, and that is rifampicin. Give a small dose, 150, increase to 300, and 450 in 7 days. Then you challenge them with INH, 100, 200, and 300. So in 2 weeks, you have 2 drugs. And then looking at the initial severity of the disease, do you also want to challenge them with pyrazinamide? It's left to you. But I would be very comfortable with giving them these 2 drugs along with ethambutol and also second line drugs, and continue it for about 9 months.
So excellent presentation. Again, going forward with the question which Sandeep posed, because we saw a lot of patients when we worked together in Bangalore as a part of medical tourism. We got a lot of patients from Yemen who have been consuming this khat, and there has been a history of consuming khat for decades together. And we have a biopsy proof of many patients who showed classical autoimmune features with significant fibrosis. So then I think so, because the insult is going on for years. So uh, is it true drug induced autoimmune, or they had underlying autoimmune? Because the treatment strategy in such patients might change as regards adding a second immunosuppressant, continuing steroids for a longer time. So thought process about that.
I would say, though, is there are some drugs that cause autoimmune like hepatitis can be associated with significant fibrosis. One CART is very well known. The other one is the nitrofurantoin. In the paper that we published, majority had fair bit of fibrosis. And some of that is even like sporadic exposure. It's not like they've been on it for 2-3 years or so. JHEP paper, that was surprising, that they would be on for a week at a time for a few years. And then we biopsy them and they had bridging fibrosis. So
Same we found with Giloy also, because there were during COVID time we had almost 35-40 patients with Giloy, and biopsy showed F3 F4 fibrosis, where the Giloy exposure was only for 3 months 4 months during the COVID time. So I think so, is it a underlying true autoimmune, or
at least in case of nitrofurantoin, we actually sequenced their HLA. Actually, none of them had the classic HLA risk factors. So I don't think we fully understand. But the point I'd like to make is sometimes you can have fibrotic disease even with drug-induced autoimmune like hepatitis.
so the immunosuppression strategy in such cases, we continue for a longer time like AIH, or we?
I would think so, especially if I have fibrotic disease. I don't think you have a choice to not immunosuppress them.
Thank you.
But definitely withhold the underlying suspected agent, and the hope is you have to have a systematic approach at withdrawing steroids at a certain time point. We don't know the duration, but definitely I would also endorse using steroids in a fibrotic patient.
Thank you.
I have one question. Hello. I have one question that we get many referrals from dermatology regarding the use of methotrexate in transaminitis, in F2, F3 fibrosis, and in CLD. So how should we approach that, and what is the role of fibroscan in it?
I just think most recent data with methotrexate are that if you don't have ongoing hepatitis C or underlying alcohol or MASH type of liver disease, the progressive fibrosis is virtually negligible. In my own practice, I just do a fibroscan every 2 years or so. I haven't seen much progression. So I think you should feel comfortable to use it. If there is true indication, then you can monitor them with fibroscan.
Yeah, recently we've also done a study of long-standing methotrexate use for almost 3 to 5 years, and we have done fibroscan. We have hardly got any evidence of fibrosis. So probably it's a overstated risk of methotrexate leading to fibrosis.
Totally agree.
And we just published it. It's ahead of print in JCEH in about 388 patients with psoriasis. And the only risk factor for development of high fibroscan scores was associated diabetes mellitus. Not the dose, not the duration, but only diabetes mellitus. And Guru Prasad Aisal's paper in Journal Hepatology a couple of years ago says diabetes mellitus as well as obesity.
And sir, what about compensated or decompensated CLD and cirrhosis? If the patient has compensated cirrhosis or decompensated cirrhosis with ascites, should we?
So if somebody has compensated cirrhosis, should we give them methotrexate?
Yeah.
In those patients, you have to be very careful. And it depends on what dose you are going to give and for how long. And since you already have fibroscan scores, you can monitor it. But then when you have so many other alternatives available, why do you want to use methotrexate.
We get referral for psoriasis and other autoimmune skin conditions.
Yeah, if you ask that, there are
And
lots of
other-
nice, good medicines that are available for psoriasis now.
Okay, thank you.
One thought process from the rheumatology side, they said that dose that we use is much less than the West. I mean, of course, the Western opinion comes that they also don't see that often. And that's the reason one of the senior rheumatologists said that we have not seen methotrexate-induced liver disease in a career of almost 30 years. I mean, and the reason they attribute is that the dose is less. Do you think it's a dose dependent or it's only duration dependent? Like,
I think we looked at the dose, the cumulative dose throughout, and some people have had 6 grams, 12 grams, and even 13 grams. Clearly, dose across studies have not shown to be useful at all. So it's the associated features. If you see a patient or patients with rheumatoid arthritis and you see patients with psoriasis patients clearly are obese. There are a lot of diabetes, a lot of metabolic syndrome. So it is metabolic syndrome, diabetes, obesity that drives the fibrosis rather than the dose of methotrexate.
Sir, please throw some light on MDR-TB regime-induced hepatotoxicity. And sir, is there any guideline like the one for the ATT for the MDR regime in cirrhosis patients for CTP A, B, or C?
Oh, yeah, you're talking of CTP A, B, and C.
Yes,
Okay,
sir.
okay.
Sir, MDR-TB regime and sir, MDR-TB regime-induced hepatotoxicity in a normal patient, sir.
So I'm not very familiar with the MDR drugs that are recently available. It's not very easy to get. You have to consult the tuberculosis center, and they watch it like a hawk. They don't just give it to you. So, but having said that, when you have MDR the disease, it's resistance to basically rifampicin first, rather than pyrazinamide than INH. So what I would suggest is, and I've seen patients. So I was in that government group which was looking at budesonide, not one, bedaquiline. And to my astonishment, although more than 1,000 patients were treated with bedaquiline, not one patient developed hepatotoxicity, not one patient. So if you can get bedaquiline, it's a great drug. Prelenamide, the new drug. These are all tongue twisters which are new drugs. Yeah, so that is one that you could probably procure. Ethambutol is one that clearly you can give them, and also one of these ofloxacillin group of drugs, levofloxacillin. So if you have 3-4 drugs, you give it for a longer period of time, and then you're done with that treatment.
Thank you, sir. Thank you. We'll be closing the session. Thank you.
Speakers, and thank you, chairpersons. I request you to be in the center of the stage for a group photograph. We now have a 10-minute tea break. We will resume the session at 4:30 p.m.